GvHD Hub podcasts, brought to you by Scientific Education Support.
Hello and welcome to the GvHD Hub podcast. Today we'll be hearing from Gérard Socié from Hôpital Saint-Louis in Paris, France.
People ask me to shortly outline the EU perspective for treating acute GvHD. Let's say that it's similar, but it's not exactly the same as in the US. The main difference probably lays with the prophylaxis of acute GvHD, since the use of ATG coming for 5 randomized trials is widely used in Europe, while it's less used in the United States. You will find in the handout I produced for the Tandem meeting a full document describing this RY treat perspective of GvHD, both acute and chronic, with 55 references of the main clinical trial in this setting. Thus, prophylaxis difference because of the use of ATG in the UK, but otherwise not really widespread in the other part of Europe. You can use anantizumab. Despite prophylaxis, as you know, GvHD still occurs, thus there is room for improvement in prophylaxis. Post-transplant cyclophosphamide PTCY has been widely used. Until now, there have been only 1 randomized trials after myeloablative conditioning regimen in the United States that have just been published recently in JCO. That doesn't prove that PTCY was better than CD34 plus selection or calcineurin inhibitor prophylaxis. We're hardly waiting for the results of PTCY from the BMT-CTN after reduced intensity conditioning. For the treatment of acute GvHD, there is no specific European way. It's use of steroids. What we know is that the dose is usually 2 milligrams per kilo per day. There have been randomized trials showing that in non-too severe acute GvHD, you can decrease the dose to 1 milligram per kilo per day. This was a Seattle randomized study. What we know is increasing the dose of steroids beyond 2 milligrams is useless, and this has been proved by an old Italian randomized trial. Could we add a drug to steroids? This was recently examined by a randomized trial using itacitinib in addition to steroids as first-line treatment. The paper has been published recently in Lancet Hematology, but failed to show an improved results. And finally, there are new drugs, especially abatacept, a nice phase 2 trial by Leslie King published in JCO last year. But this is a phase 2, and as far as I know, there is no randomized trials using abatacept running now. Thus, we use steroids, let's say 1 to 2 milligrams per kilo per day. Using more is useless. Using less is possible, but whatever the case is, we know that 40 to 50% of the patients may become steroid resistant, and we know that the outcome is then quite poor. Until very recently, there have been quite disparate literature around steroid-resistant acute GvHD with a lot of phase 2 trial, only 2 randomized trial that basically failed. But as you know, the REACH2 trial published in the New England a few months ago showed that clearly the standard of care now in steroid-resistant acute GvHD is ruxolitinib because it clearly improves response rate. However, it doesn't improve survival yet. We need the long-term follow-up of the REACH2 trial that is hardly waiting. With that, I thank you for your attention, and I hope you had enjoyed your congress, and you may reach me by mail if you have any question. Have a good day. Bye-bye.
Thank you for listening to the GvHD Hub podcast. We would also like to thank our supporters, Insight, Novartis, and Syndax.
GvHD Hub podcasts, brought to you by Scientific Education Support.